Welcome to the Lymphoma Research Foundation's update on relapsed, refractory, chronic lymphocytic leukemia, small lymphocytic lymphoma. I'm Philip, and I'll be the operator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of this program and gain certification of attendance. If you are listening by phone, this link will be sent to your email at the end of the webinar. Now I'm pleased to introduce Jessie Brown. Jessie Brown is the Associate Director of Patient Education at the Lymphoma Research Foundation. Welcome, Jessie.
Thank you, and thank you to each of you for taking the time to join us on today's update on relapsed refractory chronic lymphocytic lymphoma, chronic lymphocytic leukemia, small lymphocytic lymphoma webinar. We'd like to thank our sponsors of this webinar, Adaptive Biotechnologies, Beijing, Genentech, Lilly Oncology, and Pharmacyclics and Janssen, an AbbVie company. Before I turn the program over to our speaker, I want to briefly share information with you on the Lymphoma Research Foundation. Access to expert disease information is so important, and we're thrilled to be able to bring you this educational program. The Lymphoma Research Foundation is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate disease through an investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF can offer a variety of lymphoma-specific resources, many of which you can access at the bottom of your screen if you're utilizing the web link, or via LRF's website at lymphoma.org if you're on the phone. The LRF helpline can answer your specific questions about lymphoma, as well as discuss relevant treatment options and clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. We offer a variety of publications that have been reviewed by lymphoma experts to ensure you have access to the latest lymphoma information. Our mobile app, Focus on Lymphoma, is an award-winning app that provides patients and caregivers access to comprehensive content, as well as unique tools to help manage your disease. This app is available for free download in the Apple App Store and in Google Play. Finally, we've launched our COVID-19 Learning Center to support lymphoma patients and caregivers through this challenging time. Please visit our Learning Center for access to webinars, articles, and other resources specific to COVID-19. I really hope you'll take advantage of some of the great resources and services that the LRF provides. If you have questions regarding what you heard about today, or if you need information about relevant treatment options and supportive care resources, you can reach out to LRF through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. We have a wonderful program planned for you today, and I'm honored to introduce Dr. Alexey Danilov. Dr. Danilov is a hematologist and oncologist at City of Hope, where he's also the Associate Director of the Tony Stevenson Lymphoma Center. In addition, he is a professor under the Department of Hematology and Hematopoietic Cell Transplantation. Thank you, Dr. Danilov, for speaking at our program today. I'll now turn the talk over to you.
Thank you very much. It's always exciting to speak for Lymphoma Research Foundation, the foundation that's doing so much great work for our patients and supporting important research across the nation. So the topic of our conversation today is relapsed refractory CLL, and there's been quite a lot of development in this field in the past few years, and even in the past year, following the American Society of Clinical Oncology and Hematology meetings, there's been quite a lot of new data which is changing how we approach relapsed refractory CLL today. So let's just remind ourselves that CLL originates in the lymphatic system, which is part of the immune system, and it's typically localized to several areas such as bone marrow, lymph nodes, spleen, as well as presents with circulating lymphocytes, which is a type of white cells in the peripheral blood. And as you can see on this diagram, it is essentially of what we would say a systemic disease, because the lymphatic system as part of the immune system is present in all parts of the body, And even though it's concentrated in certain areas, there is really no part of the body where blood doesn't flow, and therefore where you couldn't potentially find a CLL lymphocyte if you looked. And in addition to that, bone marrow is also an organ which is present in all bones. Therefore, our treatments for CLL are always systemic, meaning that local treatments such as surgery and radiation are typically not an effective treatment of CLL because it does not address the problem of CLL being systemic disease. It is very important to test for prognostic indicators in CLL, and I have to admit again that I'm constantly somewhat, let's say, disappointed that I see that use of prognostic factor testing in CLL is very low in the community. Only about 40 to 50% of patients in the nation get tested for FISH, which looks for genetic abnormalities, for chromosome changes. That's on the left side of the slide. And less than 20% are tested for other prognostic factors such as IGHV mutations or next generation sequencing panels. And this remains very important in both previously untreated CLL and relapsed refractory CLL. So these prognostic factors need to be determined prior to each treatment because some of them, like the chromosome changes, do change with therapy. IGHV mutations don't change, but they should be tested at least once in the course of the disease. And NGS panels also give us more information now to understand how other important genes are affected by CLL. Some of them are listed here, NOTCH1, SF3B1, and TP53, as that also impacts treatment choice and prognosis. And again, we do that before each treatment, including in relapsed refractory CLL. So when somebody begins to progress following initial treatment, watch and wait is still an appropriate strategy. You know that we use this watch and wait or watch and worry approach in patients with previously untreated CLL, even before the first treatment is started. But say if somebody completes a course of treatment, then following that completion, as long as we obtain a response and clinical efficacy, we then again embark on a watch and wait approach. Of course, now we have some treatments who are administered indefinitely, such as ibrutinib or acalabrutinib, the BTK inhibitors, which are very popular in treatment of CLL now. So that is not so relevant there. But for other treatments like chemoimmunotherapy or venetoclax-based treatments, watch and wait still occurs. And even if somebody had some sort of treatment, and now they see emergence of lymphocytes in the peripheral blood, which weren't there before, or they are feeling some lymph nodes again after completing treatment, maybe a few years after completing treatment, it's still okay to continue to watch and wait until some symptoms develop. So, and those symptoms again will be night sweats, weight loss, sometimes fatigue associated with other symptoms, as well as anemia or low platelet counts. So, but until patient becomes symptomatic, we again continue to just watch and wait. So, in relapsed refractory CLL, there are these main treatment options. I would say that chemotherapy is really no longer a strategy in relapsed CLL. It really shouldn't be employed too much, particularly if somebody has already received chemotherapy as their first line of treatment. While one might still argue that fludarabine combinations may be appropriate in previously untreated CLL, maybe bendamustine combinations, outside of special circumstances, chemotherapy is really not the best approach for relapsed refractory disease. What could be the special circumstances? You know, these are pretty rare. For example, if somebody comes back with some immune complications of CLL, like autoimmune hemolytic anemia, sometimes chemotherapy may be appropriate. Unfortunately, if novel agents are somehow not available to the person, then chemotherapy remains an option, if not the only option. And basically that means essentially the problem of access to novel therapy. But outside of that, for most patients, we have two categories, which is immunotherapy, drugs like rituximab and obinutuzumab, which obinutuzumab is technically only approved for previously untreated CLL, but we sometimes use it in relapse. And more importantly, there are three categories of targeted agents before we go to, and clinical trials, which are used in relapsed CLL. So the BTK inhibitors, acalabrutinib and ibrutinib, is approved in both previously untreated and relapsed CLL. BCL2 inhibitor venetoclax in combination with rituximab or obinutuzumab in my practice in relapsed CLL. And then there is a new class of drug which is not used in previously untreated CLL, drugs called PI3K inhibitors. Idelalisib and duvelisib are currently approved for relapsed refractory CLL. So first we will focus on BTK inhibitors and PI3K inhibitors. So those drugs target so-called B-cell receptor signaling pathway. So here is ibrutinib, acalabrutinib, and idelalisib, duvelisib, which target BTK and PI3K respectively. And what you can see here is essentially the inside of the cell. So this blue line, this blue double line here is the cell membrane, and this is a schematic representation of the B-cell receptor, which transmits signal from outside, where you see like little green cup going inwards, to the inside of the cell, which promotes cell survival. So by targeting BTK, which is one of the key players within the B-cell receptor signaling pathways, those small molecules disrupt the survival of the cell. And same happens with PI3K inhibitors. So those are the two key targets within the B-cell receptor signaling pathway, which ultimately prevent cell survival. And ibrutinib is the first BTK inhibitor which was approved, and again, this is now also used in frontline setting. And it was approved. It basically targets the energy pocket of the broten tyrosine kinase. The broten tyrosine kinase was named for this gentleman who first discovered the disease associated with deficiency of this kinase in kids, which led to immune problems. But so when the kinase was actually discovered by the chemists, they named it after him. And the way this drug works is it binds this particular protein, and therefore this protein cannot get access to energy and cannot function anymore. These days, however, we now have new medication called acalabrutinib, which is more selective than ibrutinib, and these days it's because of certain features, particularly better side effect profile, it's finding more and more use in patients with CLL. So here you could see a comparison of kinase selectivity between the two drugs. So the less red you see, the cleaner the drug is. So you can see ibrutinib targets BTK, but it also targets multiple other proteins, whereas acalabrutinib, a second-generation BTK inhibitor, is much more selective at targeting BTK. And that is really the target we care about in CLL, and that's really the one we really want to inhibit with as much selectivity as possible. And acalabrutinib achieves that better than ibrutinib. And recently this has now been shown in clinical trials in patients with CLL. So acalabrutinib was first approved based on this trial called ASCENT. This is the trial which randomized, basically administered either acalabrutinib or a comparator treatment for patients with relapsed refractory CLL. And patients were randomized to acalabrutinib, which is the top part, or standard treatment available at the time. Patients either received chemotherapy or PI3K inhibitor idelalisib. And basically what you see here is that patients who received acalabrutinib did better. So the flatter the curve is, the better the patients do. So when you look at the red curve, which is patients who received acalabrutinib, if the curve stays flat, straight, that means that patients don't progress. If the curve goes down, like you see with the blue curve, patients who received either idelalisib or bendamustine, every time the curve goes down means that somebody has progressed on treatment and will need some other treatment at this point. So this study led the foundation for approval of acalabrutinib in relapsed refractory CLL, and in patients who do not participate in clinical trials, among the BTK inhibitors, I think it is the best choice now. And the reason why it's becoming the best choice is this. We actually have data where patients who had relapsed CLL were treated with either acalabrutinib or ibrutinib. So this is another large randomized phase 3 trial of both drugs. And this doesn't, because these drugs come from different companies, this doesn't happen as much in oncology, but it actually happened for this particular patient population, relapsed refractory CLL. In addition, this was also a high-risk population. A lot of the patients had this high-risk feature called deletion 17p. Now, deletion 17p is something which is associated with inferior outcomes in CLL. It's more resistant to therapy. It's more resistant to therapy, and it is not so common in patients with previously untreated CLL, but it is becoming pretty common in patients with relapsed CLL, particularly those patients who received chemotherapy. So if we see 100 patients with CLL who had received no treatment, maybe 10 of them will have this high-risk genetic lesion. But if we see patients who received chemo and we test them 5-6 years later, about 30 to 35 of them will have this high-risk genetic lesion. And that's one of the reasons to not use chemotherapy, because it does make subsequent treatments more difficult. Because chemotherapy is really associated with the emergence of these high-risk resistant clones. But the good news is that that is one other reason why it's really important to test for genetic chromosomal abnormalities in CLL for all the prognostic markers every time we think of therapy. So the good news, though, is that BTK inhibitors, both ibrutinib and acalabrutinib, are pretty effective in treating this high-risk disease. Chemotherapy is not, but BTK inhibitors are effective. So, and this is, again, going back to the study which compared acalabrutinib, the second-generation BTK inhibitor, with ibrutinib, the first-generation BTK inhibitor. And this is the efficacy. The efficacy between the drugs is very similar. One feature was that patients who received acalabrutinib discontinued therapy less frequently for side effects than patients who received ibrutinib. And overall, even though efficacy was similar, the safety of acalabrutinib was better. So one of the main side effects of BTK inhibitors is this heart arrhythmia called atrial fibrillation. It is particularly frequent in folks who are over 70, 75 who receive these drugs. And what you can see here that about less than 10% of patients who received acalabrutinib developed AFib, and about 16% of patients who received ibrutinib developed AFib. So significantly less common in patients who received acalabrutinib. So, and this is how it happens. So if you look at the data over time, patients who were treated with ibrutinib, yellow line, more and more of them developed AFib over time. Whereas it's still true with acalabrutinib, the overall incidence frequency of AFib is lower. There is this gap that you see between the two drugs. Another issue is hypertension. Hypertension is very common on ibrutinib. In some studies, up to 75% of patients develop hypertension. Here you can see that this number goes to close to 40%. Close to 40% of patients on ibrutinib develop hypertension, and this never really flattens. If you keep patients on ibrutinib, this curve keeps going up. With acalabrutinib, it's still a problem, but not as big of a problem. The rate is closer to 10% with acalabrutinib, as you can see here with the blue line. So these heart-related side effects are less common with acalabrutinib compared with ibrutinib. How about other side effects, such as bleeding events, less common with acalabrutinib, diarrhea, less common with acalabrutinib, and that is because acalabrutinib doesn't target some proteins which ibrutinib targets and causes diarrhea. And also joint pains or arthralgia is less common with acalabrutinib as well. So not only acalabrutinib is associated with same efficacy as ibrutinib, but also it has better side effect profile. So this is really the drug to think of in patients with relapsed CLL. Of course, ibrutinib still remains a very active agent, and if somebody is doing well on ibrutinib, there is really no point in switching them to acalabrutinib. And there are some clinical trials where ibrutinib is combined with other new drugs where patients can really benefit, and such trials may not be available with acalabrutinib, for example. So there is still a good reason to use ibrutinib in CLL. But overall, acalabrutinib should always be considered for patients who have relapsed CLL. I'll just mention briefly, there is one other drug which is also emerging. It's another second-generation BTK inhibitor, somewhat similar to acalabrutinib, and a study with this drug was also performed where patients received either zanubrutinib, this new selective agent, or ibrutinib. Very similar study like what you've seen before. And there was also better safety with this agent and fewer cardiovascular events, and particularly atrial fibrillation. It went from 10% with ibrutinib to 2.5% with zanubrutinib, this new drug. This drug is not approved in CLL yet, so it's not quite available for our patients, but it might become available in the future. So second-generation BTK inhibitors really have really have a significant role in treatment of relapsed refractory CLL. So another drug which has a role is a drug called venetoclax, and I've shown you the B-cell receptor signaling pathway where ibrutinib and acalabrutinib work. So venetoclax is a BCL2 inhibitor, which is something different. So it actually targets the mitochondrion, which is a small organelle, so to speak, in a cell, and it works as an energy station for the whole cell. And turns out that in CLL cells are very dependent on this particular little energy factory station, and particularly dependent on this protein called BCL2. So this is the study which really put a nail in chemotherapy in relapsed CLL. This is called the Murano study. And again, this is a large randomized study where patients were assigned to treatment with venetoclax, this BCL2 targeting agent, or bendamustine rituximab, which was standard chemo at the time. And so here's what happened. Patients who received venetoclax did not progress nearly as fast. As you can see, in patients with relapsed CLL, bendamustine only works for a year and a half at most. And out of this year and a half, bendamustine is given for 6 months. So it's really only a year after you stop treatment that most patients have efficacy for. Whereas venetoclax, which was administered for 2 years here, works on average for 4 years and a half in this study. Moreover, and this is very important, survival of patients who received venetoclax was better than those who received chemotherapy. So actually venetoclax helps patients live longer compared to chemotherapy, and this is a very important point. It adds years to life in relapsed refractory disease. It is also better tolerated and than chemotherapy because it doesn't have as many infections. And interestingly, the other thing which this study has shown is that in this study, patients may achieve minimal residual disease, or MRD. And this is the concept which LRF wanted us to talk about a little bit. So MRD, or minimal residual disease, is a state when we cannot see CLL by standard methods, like by computer scans. So we can no longer see or feel lymph nodes. We can no longer see lymphocytes or CLL cells in the blood if we just do a complete blood count. So MRD determination requires more sensitive tests, such as flow cytometry or more recently next-generation sequencing, but most of the time it's detected by flow cytometry. And what this study has shown, and other studies have shown that too, is that the deeper the response, meaning that in patients who achieve undetectable MRD, outcomes ultimately are better. So what you see here is a green line. So those are patients who on venetoclax who achieved undetectable MRD. So we cannot detect CLL by sensitive methods. And those patients did really well. In patients who had sort of intermediate state, we can detect some CLL by sensitive methods, but it's at a low level. They did a little bit less well, and patients where MRD was positive, so meaning that it's fully detectable, they didn't do as well. And of course that reflects the disease biology overall. But nevertheless, this is an important point. We still don't test for minimal residual disease in the clinic routinely because the trials are ongoing to determine how to integrate MRD into clinical practice. The most important point would be to determine when to stop or when to continue treatment with our medications. However, there is not enough information as of yet to make decisions based on MRD on everyday clinical basis. And sometimes your physicians may discuss this with you and say, well, you know, in your case, maybe we should check MRD because of this and this and this. And other times they would say, you know what, it doesn't make sense to check it because we won't change what we do based on the result anyway. So I'd say the latter is still more common than the former. However, some of my colleagues check MRD routinely and change treatments based on that. But so far, it still remains mostly a clinical a tool in clinical trials. So what are the treatment side effects and complications? So antibodies, when they're combined with targeted therapies, can cause some infusion reactions and infections. Like you have seen with acalabrutinib and ibrutinib, with BTK inhibitors, you can see some atrial fibrillation, which is a cardiac arrhythmia. You can see increased blood pressure, hypertension, infections, diarrhea, headaches, fatigue. So actually the list of side effects can be quite long, quite substantial, but most of them are not very intense. Headaches famously happen with acalabrutinib, but not as much with ibrutinib, for example. And finally, venetoclax can work so well that it can cause something called tumor lysis syndrome, which means that it kills so many CLL cells in the first minute or two after you take the drug that it can damage the kidneys. And because of that, we have to be very careful at escalating, ramping up the dose of venetoclax over a period of 5 weeks and checking blood work to make sure that we don't induce this so-called tumor lysis syndrome. And because it also can affect other cells, there may be a risk of infections as well, although the risk is possible with all drugs that we use in therapy of CLL. Now a few words about PI3K inhibitors. So they have so far been used a bit less prominently in treatment of CLL because of some unique adverse events. These drugs can cause some late immune system-mediated adverse events. Among them, there can be some diarrhea, pneumonitis or inflammation in the lungs, abnormal liver function tests, and some unique infections, viral infections or sort of fungal infections, which can happen with these drugs. So they are typically used after either venetoclax or BTK inhibitors are used. However, they don't cause, for example, cardiovascular side effects that much, and they do not cause tumor lysis. So there are certainly patients who can do very well with these drugs. And at City of Hope, we are trying we are actually pioneering alternative schedules of PI3K inhibitors, using them intermittently rather than every day, to mitigate all these adverse events that are shown here. The current drugs that are approved are idelalisib and duvelisib, and that's what can be used as standard of care. A new PI3K inhibitor called umbralisib is approved in therapy of lymphomas, not yet in CLL, but it has completed trials in CLL, and the results look quite promising with this drug. It seems to have a little bit fewer side effects than the others. So I'd say that the area where we head now is, in the past, most patients whom we have seen with relapsed refractory CLL would have had chemotherapy, and now they're coming back, and they can be treated with venetoclax or ibrutinib or acalabrutinib or PI3K inhibitors. So now in relapsed CLL, we also have patients who already were treated with venetoclax, and now now their options are a little bit different. So maybe they can be retreated with venetoclax, or treated with ibrutinib or acalabrutinib, or with PI3K inhibitors. There are also patients who progress on ibrutinib, for example. So for them, acalabrutinib is not really no longer an option. So their options become a little bit more limited. So it's either venetoclax or PI3K inhibitors. So we are now seeing patients who have never seen chemotherapy and who have progression on these new drugs. So there is quite a lot of research and a lot of promising data emerging in this space as well. For example, this drug, the unofficial name is LOXO-305, but now it's also called pirtobrutinib, is the drug which works in patients who progress on ibrutinib or acalabrutinib. And what's underlying progression on these drugs is mutations in their targets, in BTK. So BTK may acquire mutations in its energy binding pocket. So neither acalabrutinib nor ibrutinib can bind to BTK, to this protein, anymore. So this particular drug, pirtobrutinib, was designed specifically to target such proteins. And there is some preclinical data that it's effective in cells which carry this mutation. Now we also have clinical trial data where we have clear indication that this drug works in patients who progress on ibrutinib. So this is something new. There is no official approval for this drug yet, but my anticipation, at least, is that approval will be coming at some point soon, and that we will have this drug soon in the armamentarium of in the toolbox of treatments for patients with relapsed refractory CLL. Finally, another point is CAR T-cell therapy. CAR T-cell therapy is different than anything that I've shown to you until now. So I've mostly focused on small molecules, as this is the mainstay of treatment for CLL. This is actually cellular therapy. Basically, what happens here is patients' cells, specifically T cells, are taken from the blood. They are expanded in culture in vitro in a plastic box like this. Then a virus is introduced, and the virus arms the T cells to attack the CLL cells. So it specifically carries a particular structure which teaches the T cells, the patient T cells, to recognize CLL cells which otherwise hide from them. And these T cells are expanded again and put back into the patient, infused into the patient. And once they get into the patient, they start finding the CLL cells and eliminating them through immune mechanisms. So this is still pretty early in clinical trials, but the initial results are very good. This is particularly relevant for patients who progressed on both acalabrutinib or ibrutinib and venetoclax, as that as that introduces a completely new alternative therapeutic option, which is much more safe than, say, stem cell transplant. Okay, the only curative option for CLL right now is considered to be stem cell transplant or bone marrow transplant. So this is safer. It still has more side effects than small molecule therapy, but it's much better than transplant side effects. So this is a very exciting option for our patients. In the last section of the talk, what I want to talk about is the immune system. So we know that CLL compromises the immune system of our patients. It compromises the T cell immunity, the B cell immunity, the innate immunity, and our patients are more susceptible to all sorts of infections like pneumonia, sepsis, shingles, and others. And it's particularly important to bring up in the era of COVID pandemic, right? Because we know that patients with CLL are at high risk of COVID complications. So I want to show a couple of slides, but I think I want to say that this is probably the worst case scenario. I believe that right now the situation is much better than it was initially when this data was published over a year ago. But you can see that when patients with CLL contract COVID and become symptomatic and get to the hospital, almost half of such patients die. So patients with CLL need to exercise particular care in terms of avoiding any sort of avoiding COVID and of course getting vaccinated. So I do believe this is a little bit of the extreme. Those were patients in the ICU, who came to the hospital that were selected. So it's really not everybody with COVID, everybody with CLL who had COVID. I don't think the reality is as grim as it shows here, but we know that patients with CLL do have higher risks than anyone else. So it is important to keep that in mind. The other concern with patients with CLL is that they do not respond to vaccines as well as healthy individuals. So CLL compromises response to vaccines, and that's been shown in earlier studies with hepatitis vaccines, for example, and now we have similar data with COVID vaccines. So here is something we can expect in patients with CLL who get vaccinated with COVID vaccines. So if somebody has untreated CLL, the response rate is 50-70%, which is not terrible. So about 2 out of 3 patients respond to COVID vaccination if they have untreated CLL. And it may be also even higher if we administer a booster. So that data is not there yet, but it seems that a third vaccination may help further increase the responses to vaccine. However, if somebody is currently being treated with ibrutinib or acalabrutinib, responses are 20-30%, so they go down. Same with venetoclax, responses are 20%, 20-30%. So if somebody is on active treatment, they really don't respond as well. And in particular, if they're being treated with rituximab, obinutuzumab, or have been recently treated with these agents within 6-12 months, then the response rate is less than 10%. So these drugs, because they target B cells, which is one of the key antibody producing cell, they basically don't respond to vaccines as well. So, however, these antibodies are usually not continued forever. So usually there is a light in the end of the tunnel as to when they can be stopped and when vaccinations can be repeated or booster can be administered. And again, as far as we seem to know now, responses do seem to improve with vaccination boosters, so it is important to get this. In my clinical practice, if somebody is on acalabrutinib, I still recommend that they get vaccinated even while they are on acalabrutinib. Even if it's a chance of 1 out of 3, I think it's better than 0 out of 3, right? So, and also, I don't know, it is possible that even though we don't see these antibodies produced, it is possible that vaccine still renders protection via other mechanisms like T cells, other immune mechanisms other than just antibodies. This is what we learn by testing for anti-COVID antibodies after vaccinations. So overall, it is exciting time in relapsed refractory CLL, and with lots of different agents coming down the pipeline and already currently being approved. And I wanted to leave 20 minutes for questions pertaining to this field. Thank you very much.
Great. Thank you so much, Dr. Danilov. We'll now begin our Q&A portion of the program. Just as a reminder, please keep your questions as general as possible. And if you'd like to ask a question, please submit your question through the Q&A box on your screen. We'll take as many questions as possible, but if you have a question that doesn't get answered, you can always reach out to our LRF helpline at 800-500-9976. And we have our first question that came in. Someone asked, has venetoclax been given as a solo treatment?
Yes, so venetoclax has been given by itself, and this is it's actually in how it was initially approved. And for patients with deletion 17p, it was approved as a solo treatment. So it is possible to give it without an antibody.
Thank you. Next question, someone just wanted you to expand if the presence of particular genetic abnormalities influence your treatment selection for patients.
Yes. So, if somebody has deletion 17p, chemotherapy is really not right for them. They shouldn't get chemotherapy at all, unless there is some issue where they cannot get anything else. Also, patients with deletion 17p may have the responses to venetoclax may be a bit worse than patients who don't have deletion 17p. So that's something we also discuss with patients when we decide between, say, venetoclax and acalabrutinib, or when we start talking about clinical trials. So, yes, that's one example of how treatment may be affected, and that's probably the most important example.
Great, thank you. Our next question is, should all Pfizer recipients who have CLL seek out the booster?
Yes, I would say so. Unless there was some problem with initial vaccination, I guess. But barring any issues, yes, I would say they should.
Thank you. Could you comment on the future prospects for U2 treatment, umbralisib plus obinutuzumab? My specialist is excited about this one.
Yeah, so I've been involved in trials with this combination. We still have trials with this combination ongoing in CLL and other lymphomas. That combination does work really well. As I mentioned, it seems to be a little bit. It seems to have fewer toxicities a little bit than idelalisib, duvelisib. I do find that it's better tolerated by patients than other PI3K inhibitors so far. I also really like the obinutuzumab antibody, which is a CD20 second generation CD20 antibody. It is very effective. So it is not approved in therapy of CLL yet, but the Unity CLL trial has been completed, and we reported it multiple times already. It does show benefit compared to control arm in both previously untreated and in relapsed CLL. So this regimen, I believe, has a future.
Great, thank you. Does FL have the same effect on immunity as CLL?
Yeah, it is the same disease. It's really a terminology issue. If we see lymph nodes but not so much circulating lymphocytes, then it's termed SLL, small lymphocytic lymphoma. If we see circulating lymphocytes, even if lymph nodes are present, then we call it CLL, but it's really the same disease. That's why it's often termed CLL/SLL.
Thank you. Our next question is, someone said they have been on ibrutinib for the past 6 years, and they're starting to see a rise in WBC or white blood cell count. Is acalabrutinib a possibility as next treatment option?
Well, so if it is a true progression on ibrutinib, likely not. So true progression on ibrutinib would be due to mutations in BTK. And the way acalabrutinib and ibrutinib bind BTK, their target is the same. So if patients develop mutations in BTK, they won't respond to acalabrutinib. So likely it's not. It is not then an option. I mean, there can also always be some sort of circumstances where that's not true, but I'd say with 90% confidence, probably not an option. The options would be, participation in a clinical trial. Option will be venetoclax, PI3K inhibitors. So venetoclax and PI3K inhibitors are approved options. And as I mentioned, pirtobrutinib is not approved yet, and there are some other new agents in development which are investigated in BTK resistant CLL. We have a trial, for example, with a compound called PROTAC, proteolysis targeting chimera, which doesn't only inhibit BTK, it also degrades it, meaning that it's lost in a cell. So that's another very exciting, mechanistically and therapeutically very exciting area, which we study here at City of Hope. So there are other very good options these days.
Thank you. Our next question is: do you recommend treating with monoclonal antibodies if COVID develops?
So monoclonal antibodies, like COVID-directed, is that what the question is about? So
yes.
If COVID develops, we actually have pretty stringent guidelines in terms of what we do. If patients become symptomatic, there are some antibodies like Regeneron, like what President Trump got, which can be administered to decrease the risks, it wasn't available in the past, but it's available now. So some neutralizing antibodies. So yes, but it typically follows a pretty strict scenario in terms of what we do and when we administer these antibodies. But in principle, yes.
Thank you. Our next question is: are there any new signaling pathways under investigation as possible therapeutic targets beyond the 3 pathways that you described?
Yeah, so yes, for sure. Like in our lab, we actually work with something called CDK9 inhibitors. We have clinical trials with CDK9 inhibitors now. So CDK9, or it's a short for cyclin-dependent kinase 9, it's one of the proteins which drives production of all proteins in a cell, and CLL cells become particularly susceptible because they rely on this particular protein in their survival as well. So CDK9 is one target. There are several agents now in development there. And another, for example, target in development is something called BAF. That's a surface antibody, B-cell activating factor. We also happen to focus on that at City of Hope. One of my colleagues, Larry Kwok, has projects going in that space. It is also a very interesting target in CLL and other lymphomas, and we have shown it can work really well, and Dr. Bird's lab has had some data in that as well. Then alternative pro-survival proteins like MCL1 is a target being investigated. Other surface targets such as CD19, we actually have a project at City of Hope as well where we target CD19, which is similar to CD20, so it will be similar to rituximab, but it's a different target. So yes, certainly there is a number of other targets which are being investigated in CLL.
Great, thank you. Someone asked, since there are a number of treatment options for relapsed refractory CLL, SLL, how is the best option for treatment determined?
I think, well, it really depends on two things, I guess. Well, three things. So one is what was the treatment which was administered before? If somebody received ibrutinib, progresses on ibrutinib, and then ibrutinib is no longer a good treatment, or acalabrutinib is typically no longer a good treatment option. The second is what are the genetic features? What's the IGHV mutational status? What's the FISH result? What is the carrier type and whatnot? And the third option is who is the patient? The third component is who is the patient? What medications do they take? What kind of medical problems they have? Are there any relative contraindications to use of this or that agent? Like, for example, if somebody has ulcerative colitis, I wouldn't necessarily use PI3K inhibitors. If somebody has poorly controlled atrial fibrillation, I wouldn't want to use BTK inhibitors. So those three factors ultimately determine what treatment is being used.
Thank you. Seems to be our last question at the moment. Someone asked, if my doctor has not done genetic testing, how do you suggest I advocate to ask my healthcare team to do one?
You can just ask them. I'm sure they'll be fine with that. You could just say, look, I heard about FISH as one of the prognostic factors. Have you tested for my, have you done FISH before? Is it possible to do one? It is never a problem with insurance companies, so it is not an expensive test anymore. So insurance approval is not an issue. I guess maybe rarely. I guess anything can be an issue in principle, but typically it's not. So I would just ask. Patient come and ask me what's my FISH result. so I don't think it's a problem to ask.
Great, thank you. We got one more question that came in. This is also another booster shot question asking if Moderna recipients should get a booster.
So my understanding is currently it's approved for both. This changes every minute. So my understanding is that boosters are approved for both Pfizer and Moderna right now, not for J&J. So then the answer is yes too.
Great, thank you. One more question came in. When should I seek a second opinion for treatment?
So I guess there is never a bad time. I mean, I always encourage second opinions and patient because it's a big decision, right? So you basically commit to something which will affect the next few years of your life. And when you put that in context, going somewhere for a 30-minute long second opinion is always a good time investment. It makes more sense closer to when you are ready to start some sort of treatment, but it's never a wrong thing to do.
Great. Well, thank you so much, Dr. Danilov. It seems to be our last question of the day, but we really appreciate you taking your time today. And we also like to thank everyone else for joining us on today's call, and we hope you found the information both informative and also hopeful. We'd like to thank our sponsors again for making this program possible: Adaptive Biotechnologies, Beijing, Genentech, Lilly Oncology, and Pharmacyclics and Janssen and AbbVie Company. Please remember, if you have additional questions or you'd like to be connected with someone else who has been impacted by lymphoma, you can reach out to the LRF helpline at 800-500-9976. Also, at the conclusion of this program, you'll receive an email prompting you to complete a program evaluation. I'd ask that you please take a few moments to complete this, as they are important for helping LRF to ensure that we deliver the most useful and meaningful programming to you. And with that, I'd like to thank you all again for joining us. And
I'm sorry, I actually see another comment. I actually would like to respond to that from Michael.
Oh, sure, please do.
Yeah, so Michael says each Pfizer vaccine has more adverse reactions, and booster was a week of adverse reactions. So yes, and I can totally believe that. Everybody reacts a bit differently to vaccines. Some people don't have adverse reactions and have great immune response. So there is not necessarily a great correlation. But yes, it's true. Some folks have adverse reactions to the first one or to the third one. So everybody is a bit different. I would think about this in this way, though. When we start treatment for CLL or any cancer, there are adverse reactions, which you wouldn't get if you don't treat CLL, right? So then it becomes a balance of, well, cancer is typically a deadly disease, so am I going to tolerate adverse reactions to extend my life? I think of COVID the same way. Yes, vaccines have side effects, and it can be weak of adverse reactions, but also people die of COVID. So I would keep that in mind, I would think of it as a balance, whether the risk of adverse reactions and what they potentially are outweighs the risk of dying of COVID or not. For everybody, it's going to be their individual answer, so they will think of that for themselves specifically. But this is how I try to think of it for my patients.
Great. Thank you, Dr. Danilov, and thanks for catching that at the end when that came in. And once again, we really appreciate you taking your time today, and we thank everyone again on the call and hope you all have a wonderful day.
All right. Thank you.